Hi everyone. Today is the 22nd of March 2018 and I'm going to talk about another childbirth truth. You notice that I'm running two series at the moment. One's a Fathers to Be series from conception to 12 weeks and this childbirth truths. So today we're going to talk about another hot topic, this cascade of interventions. Now, why am I an expert in all of this? Because I gave birth in 1970 before that term was even used. So I know where it came from, I know why it arrived, and I know what it's doing and what impact it's had on the childbirth conversation. And the reason our trust is so outspoken with debunking the myths of childbirth and talking about the truths of childbirth is that the childbirth conversation that has gone on since the 1980s has really confused so many of us and has been so misleading. So when I gave birth in 1970 in the United States, most of us were just going to the hospital and had an obstetrician, and there were staff obstetrical nurses. And you'd go into the hospital and you would expect, didn't always like, but you would expect assessments, any type of monitoring, and any type of procedures that were the standards of care or the evidence-based practice of that day. So that was just what was expected. We called them assessments. You had your blood pressure checked, or there was a monitoring or an assessment, and the baby's heart rate was checked, and you were given a vaginal exam, and then you had the procedures. In 1970, you were shaved, given an enema. You were in bed, you couldn't eat, your husband could come in with you. So those were the standards of care. That's what we expected. Didn't always like them, but that's what going into the hospital was. And that's why a lot of people were choosing to have home births as well, is that they didn't want those standards of care. And in fact, the Bradley method and the Lamaze method in New Zealand, where our trust is now, the Grantley Dick Reed method, those three obstetricians were seeing this standardization of maternity care. And they were saying, no, we don't need it all the time. It's for when we have a problem. But the question that the obstetrical model came back with is, how do we know if we're going to have a problem if we don't assess and if we don't monitor? So a lot of things that were up for grabs actually were the procedures. So you're not being shaved now, and you're not being given an enema most likely. So that's good news. You can probably eat and drink if you're in labor. So where did this term cascade of interventions come from? And that was curious to me because it sort of arrived out of the blue. And it arrived out of the blue from these assessments, monitoring, and procedures. So when you took a look at them and said, do women really need to be shaved and given an enema when they go to the hospital, the answer was no. Why? Well, there was a reason why they did that. They didn't do it to be mean. So if you go back prior to penicillin, which was after the Second World War, and you go prior to really the obstetrical model. So the obstetrics profession in the United States started in 1951. So if you go back to the 20s, in New Zealand, where I live now and our trust is, New Zealand had the highest rate of maternal deaths after birth due to sepsis, which meant that women got infections after the birth and they died of blood poisoning. So the reason that people got shaved and had enemas was to prevent sepsis. It wasn't that they were just going around and going, girls, you need an enema and you need to be shaved. So all the assessments and monitoring procedures come from a belief that if we assess and we monitor and do procedures, the health of the mother and the baby will be safeguarded. So we may not like them and we may not need them individually, but it's very hard to determine whether you fall into a statistics or whether you don't fall into the statistics. So things like when, you can't go past 42 weeks of pregnancy without being induced. That wasn't something that was around in 1970. They couldn't determine due dates as accurately back then. We couldn't determine we were pregnant as quickly. They didn't have urine sticks. So the fact is that things have changed, and the medical profession has changed, and the standards of care have changed, and the evidence-based practice has changed. Oh my God, whoa. And now we have what's called this cascade of interventions. So the natural birth movement, which was around in the 50s, and they were the ones who sort of made the first really big mistake in childbirth, and it was led by these three amazing male obstetricians that developed these three skills-based methods, but they focused them only on those women who wanted a natural birth, pain-free labor, believe it or not, and less medical care. So the first mistake was that in the 50s and 60s, if these three obstetricians, Lamaze, Bradley, and Grantley Dick Reed, Birth Without Fear, had said, every pregnant woman is doing the activity of giving birth. Every pregnant woman should be skilled to do this activity. Every father who's going to be in the birth needs the skills to help her do the activity. And why? What's the goal beyond health and safety? Cope, manage, deal with, stay on top of, be in control over something that is unfolding in a way that you didn't plan or expect. So those skills, the first mistake we made in the childbirth conversation back then was not attributing skills to all birthing women. We would not be having this conversation today. Honestly, 70 years later, 2 generations later, had these three men and the birth advocates, the women who are birth advocates, if they had just said every pregnant woman is going to do the activity, if she's conscious, use skills. Every father who's going to be there, have the skills to help her. That didn't happen. So not enough women achieved those natural births, pain-free labor with less medical care. So the natural birth advocates that came next in the 70s and 80s said, skills don't work, they're not necessary, you don't need them. Second mistake, yes we do. And so what natural birth advocates focused on was choice. And just like the natural birth advocates prior, who were focused on skills as achieving these three goals, the birth advocates who wanted choice really wanted women to choose to say no to the assessments, the monitoring procedures, to say no to being shaved, to say no to having an enema, say no to having to be staying in bed, to say no to not being able to eat or drink, to say no to having a standardized episiotomy, to say no to babies being bottle fed, to say no to having to stay in the hospital for a week, which, by the way, I have to tell you that the reason women were stayed in the hospital for a week or 10 days was prior to washing machines, prior to cars, prior to supermarkets, prior to disposable nappies. Women had to do all that work. Right? They had to grow food to feed their kids. They often had to make clothes. They had to wash diapers by hand. And you know what? Hospitals said, let's give women a break after they have a baby. So let's feed them and nurture them for a week or 10 days. So the intention was right. Well, by the 80s, people were saying, we don't need to stay in the hospital. We want to go home. So how's that working for us? For some, very well, and others, not so good. Hey, so in the 70s and 80s, when this new group of birth advocates came along, they were saying women should have choice. And what they meant was that women should say no to medical care. And so it was challenging to say, to list all of the assessments, to list all the monitoring, to list all the potential procedures. And they just lumped them into one word, interventions. And it was with a clear intention to imply to us as women, from other women, that those assessments, those monitoring, those procedures were unnecessary and imposed on us by the standards of care of the day. And they were, right? But here's the trick. If you don't want to have assessments, monitoring, and possible procedures around your birth, do not go into the hospital and don't have a midwife. Just do it at home by yourself. That's as simple as that. Because once you get into any system, whether it's a midwifery system or whether it's an obstetric and a hospital system, their belief is as care providers that by assessing and doing monitoring and some procedures, that your health and well-being of you and your baby are better safeguarded. That's up for grabs. However, is there this cascade of interventions? In other words, if you have an enema, does that mean you have an induction? Nope. If you don't have an enema, does that mean you won't have an induction? Nope. So if you can't get out of bed, does that mean that you're going to be given pain relief? Nope. If you can get out of bed, does it mean you won't want pain relief? Nope. So the fact is there isn't really a cascade of interventions. But this is where our trust, Common Knowledge, which is New Zealand Registered Charitable Trust, we put all of the skills that I developed in the early 70s with hundreds of ordinary mothers and fathers. And it was a time when people were seeking to be skilled for that normal birth, and I worked with families. And I don't have a political interest in birth. I did body work, but I worked with a lot of families that developed these birthing better skills. And they were families from all backgrounds, having all types of births. And what they saw was that those three methods, Grantley, Dick Reed, and Lamaze and Bradley method, didn't suit them. Either they had tried using the skills and they hadn't worked, or they weren't trying to achieve a natural birth, or they couldn't have a natural birth based on the health of the well-being of themselves, or they just didn't want a natural birth, or they were being pressured into the standards of care of the day, whatever. The cesarean rate was only 4.5%, so we weren't dealing with people who were really planning cesareans. That came later. But we were dealing with women who had had previous cesareans who wanted to have a trial of labor or vaginal birth after a cesarean. So the Birthing Better families were very serious about developing very effective skills to prepare the pregnant body for birth, and the birth and birth coaching skills so that women could cope. And the reason we prepared our body for birth is that the common reasons why we had more procedures done, and sometimes more monitoring done, is that we had a failure to progress in the dilation phase of labor, or a failure to progress during the pushing phase, or we weren't coping. And obstetricians and midwives and obstetrical nurses could see that. So when we are not coping, they want to help us. You may not like how they want to help you, but that's what they want to do. They want to help you. So they offer you pain relief. You may not respond well to the pain relief, or you may be very glad that you had it. So the pain relief in maternity care has to do with the fact that we don't have a skilled birthing population. And we have less of one now than we had in the 60s and the 70s. Because the natural birth advocates said, see, skills don't work to achieve those three goals of a natural birth, pain-free labor, and less medical care. So let's let women choose not to have medical care. Well, that's not working either. We now have a cesarean rate, even in New Zealand, under a midwifery-led maternity model since 1990. The cesarean rate's now 30%. So choice isn't working. So we need to go back and rethink the conversation. And we're going to raise our hand. We know how to do it, right? And that is skills for everyone. Period. Make a birth plan of your choices. Learn skills, whatever system you use. Birthing Better is one of them. There's active birth. There's hypnobirthing, hypnobabies. There's Lamaze, there's Bradley, there's Birth Without Fear, there's Calm Birth, Birthing Within. All those are focused on natural birth. Pregnancy yoga, Birthing Better is focused on all births. And there's differences. Those births were created by individuals. Birthing Better is created by hundreds of mothers and fathers for all births, and really focused on extensive skills to prepare your body for birth and the coping skills that you can use together in any birth. So if we have more skilled families, then the women will behave better, the fathers or others will know how to help the woman, and because if they've used Birthing Better skills, they will have more effective first stages, the dilation stage, and infinitely more effective second stages because they've prepared their baby's birth canal. So both of those things, the delay in first stage, delay in second stage, are hugely reduced when people use the Birthing Better skills. And they hugely cope better, and their partners hugely help better. Win for everybody. So what this means is your obstetrician, obstetrical nurses, and midwives see you coping and managing better, see your partner helping you better, and see that your birth is moving along better. And if you're having a non-laboring cesarean, they see you focused and calm and relaxed and engaged in the birth of your baby. This is important. So there is no cascade of interventions. The reason that women have more interventions is because they lack skills. It's a direct correlation. If you haven't prepared your body to labor, to let a big object out by creating space, mobility, and softness in your body, then you are more likely to have a delay in first stage or the dilation. If you have not prepared your baby's birth canal, you are more likely to have a delay in second stage because you have a big object coming out of your body. Like I had a big object coming out of my body. So I used Lamaze for the first birth, and by the time I had my last baby, I had developed these skills with hundreds of families. So we knew they worked. So if you want to have less medical care, then becomes highly skilled and make certain you use those skills because your behavior is being seen. Your progress in birth is being seen. And if you're moving along fine, even with multiple high risks, and you're coping beautifully with multiple high risks, as long as those risks aren't becoming a problem, your obstetrician, staff obstetrical nurses, or midwife will be very engaged in working through what are absolutely necessary assessments and monitoring, and perhaps some procedures, but you will be in a much better way to negotiate than if you're not coping or if your birth is being delayed or hung up. So, how do you help our charitable trust? Go to PayPal and give a donation at info@birthingbetter.com. We'd love that. That helps us continue. Our YouTube channel, Birthing Better Childbirth Preparation. This is on Facebook, so you can share it. You can comment. Start to engage with us and have a conversation and talk to other people that are pregnant. Sure, we'd love you to purchase our resource because all proceeds return to our charitable trust. And it allows us to continue with the goal that we have, which is to now heal the gap in the childbirth conversation and to marry skills and choices. Because if you get the choices you want, skills will enrich your birth. If you don't get the choices you would like or want, skills will enrich your birth. There is no reason not to become skilled to birth your baby. So see you again tomorrow. Bye-bye.